Please outline your approach to diagnosis and management of this patient. I would start both my diagnostic workup and management plan of this patient concurrently. I would do my ABC first, check the patient's airway and manage it accordingly, check the patient's breathing, monitor his oxygen saturation, and give oxygen accordingly if needed. I'll check the patient's circulation, circulate the vitals, check the blood pressure, and insert IV line, check the volume status, and give fluids or diuresis accordingly. In the meantime, I would put the patient on a monitor, insert a Foley's catheter, and reassess on a daily basis for removal while I'm using the urine output and weight on a daily basis. Also, I would check the patient's glucose via a CBG and do a pregnancy test since that she's in reproductive age. My differential diagnosis initially would be very broad. I would think about vascular causes like clots, thrombosis, hypertension. I would think about infectious causes, bacterial, viral, or fungal. I would think about toxins, review the patient medication, check if he's taking any alcohol or recreational drug use and herbal medications. I would check for any trauma or injury recently. I would check for autoimmune and allergic causes like SLE, rheumatoid arthritis, vasculitis, and review his allergies. I would think about metabolic causes like endocrine causes, thyroid, adrenal, hemochromatosis. I would think about iatrogenic, idiopathic causes if there's any recent medication or instrumentation. I would think about neoplastic causes, age-related. And then I would go organ system related, given that the patient presented with organ specific symptom. And then I would keep deadly causes of shock on top of my head while I'm assessing the patient history and physical, which are distributive, cardiac, and hypovolemic shock. Differential diagnosis, I would do a focused history and physical examination, starting with a past medical history, medications, allergies, social history, and family history. Specific questions about his history of present illness, chief complaint, manifestation, chronicity, severity, associated symptoms affecting his lifestyle, screening for causes, consequences, complications, systemic review. Moving to the physical examination, starting with the vital signs, general inspection, see how the patient is doing, is he under stress or not, and then orientation. And then specific examination starting systematically from the hand to see if there is any signs of systemic illness from the hands, clubbing, primary edema, checking his pulse, head and neck examination, eyes, mouth, JVP, and pulse with lymph nodes, cardiopulmonary examination, abdominal examination, lower lip examination, and CNS examination. For investigations, I'll start with the basic blood work, including CBC, light creatinuria, urine analysis and microscopy, troponin, D-dimer, septic workup, toxin screen, autoimmune vasculitis workup, including inflammatory CRP, metabolic causes with TSH, extended lights, glucose, osmolarity with blood gases and liver enzymes. Malignancy and neoplastic causes are broad, but I would start with SPEP in this case. Next, I'll move to imaging, start with chest X-ray, abdominal X-ray, ultrasound, echo, and CT scan if needed, with special tests, ECG, pulmonary function test, and nuclear scan if needed. I would manage this patient both acutely and putting a long-term plan for him. My acute management would be to do my ABC first, check the patient's airway and manage it accordingly, check the patient's breathing, monitor his oxygen saturation, and give oxygen accordingly if needed. I'll check the patient's circulation, circulate the vitals, check the blood pressure, and insert IV line, check the volume status, and give fluids or diuresis accordingly. In the meantime, I would put the patient on a monitor, insert a Foley's catheter, and reassess on a daily basis for removal while I'm using the urine output and weight on a daily basis. Also, I would check the patient's glucose via a CBG and do a pregnancy test since that she's in reproductive age. After stabilizing the patient, I would do non-pharmacological and pharmacological management. Non-pharmacological include reviewing the code status and goals of care with the patient, calling his family, counseling him about his disease, and consulting the appropriate service with allied health, RTOTPT, moving the patient to a more monitored setting. And then moving to the pharmacological, I would prescribe the appropriate medication with the dosage and duration after consulting with appropriate service and local pharmacy guidelines. Moving to, and I would counsel the patient about the indication of the treatment, side effects, complication of the treatment, and to follow up with blood work. Long-term plan for him is going to be a non-pharmacological and pharmacological management as well. Non-pharmacological would include lifestyle modification, smoking and alcohol cessation, diet and exercise and weight loss, vaccination in an appropriate age with cancer screening as well, rehabilitation center referral with OTPT as an outpatient, counseling the patient about the disease again with education medical bracelet, social support with family and referral to social worker with driving restriction as well, specifically to the disease, and I would review the local driving guidelines. And then pharmacological, I would counsel the patient about compliance with their medication.